Hi, everyone. Welcome to the Squirrel Space panel discussion about neurodivergence, well-being, and mental health. I'm Emily Kapsikevich, and I'm the founder of Squirrel Space, and I'm just happy that we're all here for this discussion. To set context, I thought this would be a helpful panel because, I have ADHD, and as I have learned more about what works for me, I've noticed that some of the things that I typically hear about for kind of health and well-being haven't always worked for me, or haven't always provided all the options that are available. And as I've learned more and more, the good news is there's a lot of services that are very helpful and a lot of people that are helpful. And one of the areas that we're focused on at Squirrel Space is helping to provide more education and just to create more awareness about services and information, so people who are neurodivergent or are allies of people who are neurodivergent are able to help suggest or recommend or share information about the services. So just that's a bit of context. So I thought to start off, I'll hand it over to AJ, who will kind of start to facilitate this conversation, which I think is starting with intro. So I will hand it over to AJ.
Thank you for the lovely introduction and the handoff, Emily. So we're going to get started tonight. We're going to have all of the panelists introducing themselves one by one, and then we'll have a nice controlled discussion in terms of, as we move through, there'll be a time for some support elements and some Q&A on the back end. So again, we're reminding everybody that there'll be time at the end of the meeting to ask questions from the panelists as well. So I'll start off by who would like to go first from the panelists? Any volunteers who would like to go first?
I'll go.
Thanks, Catherine.
Hi. Yeah, my name's Catherine Walters. I'm a speech language pathologist and communication coach. I own my own private practice, eSpeech Cafe, and I'm also currently collaborating with Kristen Sheehan, a psychotherapist, for a program we call Creative Connections. And we'll talk more about that later. Yeah.
And who would like to go second?
I can go. Hi, everyone. I'm Myrna Mejia. I am a certified professional coach. However, my first career is I've been a clinical psychologist as well. I still have my private practice, my private therapy practice, which I'm phasing out, and then I'm ramping up my coaching practice.
Very nice. And another volunteer.
Jump in. My name is Kristen Sheehan. I'm an EMDR and somatic psychotherapist. I have a private practice, and I work with teens and adults who live in California, Colorado, and Virginia. And as Catherine mentioned, I'm the other half of Creative Connections, a somatic and art-based workshop.
Very nice. And who would like to go next?
Hi, my name is Emmanuel Ramos. I have spent most of my career in the talent acquisition and people operations space, but I also really enjoy career coaching. Specifically in the tech and the creative space, we find people from all different walks of life and all different abilities. And I've always found my passion to be building inclusive environments where we can really highlight people's strengths and not so much focus on one another's differences. In the personal coaching aspect, I enjoy helping folks kind of realize those strengths and also make sure that any challenges that they come across naturally aren't always surfacing in the workplace. I consider myself a workplace ally and career coach.
And Jasmine, you want to go next?
Yes, I'll go next. My name is Jasmine Matthew. I am a certified therapeutic recreation specialist or a recreational therapist. I own an adaptive dance company called Jasmine's Beat as well. And we cater to students of various disabilities. And we partnered with Squirrel Space to provide another option through personally motivated recreational leisure pursuits to provide overall health and well-being for the neurodiverse population. So I'm very excited to show you how that works later on today.
you. Thank
There
you.
you go. I'm Prescott Leach. I'm a neuroscientist and in vivo pharmacologist. I've spent my career looking at preclinical drug discovery efforts for diseases like neurodevelopmental disorders and also ADHD, anxiety, depression, and the like.
Awesome. Do we have any other panelists hidden in here? Good, guys. Okay, awesome. So Emily, I have a question for you. When we move through topics 1 through 7, what's the format here? Is this loose? Are we talking about these individually? Are we handing these off to panelists? What's the plan?
I think we're just hitting on the panelists. So the topic 1 through 7, I think we have panelists assigned. So topic 1, the panelists are Marina, Catherine, myself, and Kristen. So you can go ahead.
Okay, we'll start with our first topic, understanding neurodevelopment health and well-being needs.
I can go first. I'll brave the topic. I just thought it would be helpful to just for a moment talk a little bit about what neurodiversity is before we talk about what challenges are commonly experienced. And again, I'm a speech therapist, so I'm coming from this place. But yeah, neurodiversity, what is it? It's a framework to honor these differences, these neurological differences that are variations, natural variations of the brain, and not deficits. And it's a way to recognize that people experience the world in, their unique different ways. They communicate differently, process information differently. And it's also important, I think, to also acknowledge the different frameworks that also, and the other frameworks, like the clinical framework, so where am I going with this? Traditionally, we saw these, what we now are discussing as natural variations, as clinical diagnoses, and these clinical labels do exist to help people get support and accommodations, but using, the neurodiverse framework helps bring nuance to it. And some things that are included as neurodiverse are things like ADHD and autism and dyslexia and learning disorders and sensory differences. So what are challenges commonly experienced in the neurodiverse adults? So from my perspective as a speech therapist and communication coach, one of the most common challenges that I see facing this population is communication. It related to communication, and many of the individuals I work with have autism, some ADHD as well. Actually, it's very common, or both. And so I see social communication challenges and differences occur more frequently in these populations. Executive functioning is another huge area that I see become challenges with this population. So planning and organizing and managing time, working memory, and that kind of thing. And also, I just wanted to mention that for adults with ADHD, we sometimes see social communication differences that usually stem from attention and impulsivity or regulation differences. And not necessarily a social communication disorder. So and I could go on, but I feel like I need to share the floor with
Very nice. Good, that's good.
you. Yeah.
So who would like to go next? Would you like to do the same topic, or would you like to move to the second question? It's up to you.
Let's maybe stay with the topic. It looks like Marina was about to jump in. So let's go to Marina.
Yeah, I mean, Catherine, you've hit so many important points here, And I wanted to quickly add from the clinical perspective. So my role as a psychologist and working most with folks with ADHD. ADHD really has a high rate of co-occurring other mental health conditions like depression, anxiety. I mean, I've looked at a lot of the research over the years, and even though there's a range, but I've seen it as high as 70% of folks with ADHD also have at least one other mental health condition. And we can have a whole other discussion on why that is. But the point that I want to make is that whenever we are talking about ADHD, assessing for it, we really have to broaden our focus and really do a sound assessment as to, are there other things that could be complicating like treatment planning and goal progression. So just wanted to put that out there as well.
Yeah, kind of building on that, I'll share my perspective just for having ADHD. Is one of the challenges is it presents so differently, especially being a woman. You know, what you hear about like being typical has often been described, in my opinion, for males and for men. And so it makes it challenging to have like one standard path that works for everyone. And so one of the things that I noticed when I was growing up, and then as I continued to face challenges just based on where I was in life, is not knowing what's normal, even for someone who's neurodivergent. And that's one of the challenges I faced. And we'll get to this later, but what I found to be especially helpful was coaching. And so I think empowerment is another theme that I find to be challenging within the neurodivergent community, because there has been, you know, just a lot of change and evolution in our understanding of the topic. And it's made it hard, I think, for people to understand what they should be asking for, or if it's going to work for me personally, because we are so different. The other thing I thought could be interesting to highlight, and Prescott, not to put you on the spot like I just did, is I think it's helpful to also share that the language and that the way that different people in the professional and medical community are taught and trained about neurodiversity is very different. So Prescott, maybe you could just share some of your training and how you were trained and taught to think and understand neurodiversity.
Yeah, I think so. I got my PhD in psychology and neuroscience back in 2014, and I actually had not heard the term neurodivergence until the last 2 years. So it was well after I, gone to school and gotten my education on the topic. I'm not a practicing clinical psychologist, so if I was, I probably would have heard it sooner. But I find that interesting that it is kind of a more newly developed framework, as you guys were saying. And I'm here to learn more about using that framework.
Yeah,
Thanks.
I'll jump in with a couple things as well. I noticed in my private practice, a lot of neurodivergent folks are coming in having been misdiagnosed by a therapist or a psychiatrist. They might be misdiagnosed with a personality disorder, OCD, bipolar disorder. So without the right diagnosis, you can't get the right care. And that's not to blame providers. As Prescott said, this is kind of a new term and something we're still learning about. So I think there's a lot of room for more awareness and education, as we're doing now, opening up conversations. I also see a lot of sensory dysregulation and sensory overload. And that can show up as even being disconnected from the body, not recognizing hunger, tiredness, pain. And I see the eating disorder known as ARFID, avoidant restrictive intake disorder, showing up more and more in this population. And it's really kind of a nervous system response to sensitivity to textures, smells, temperatures. And this can lead to some health issues like malnourishment, dehydration, and just uncomfortable symptoms. So in addition to everything that's been said, those are a couple specific things I see, as well as the masking and self-monitoring and rejection sensitivity. And yeah, there's so much that encompasses this.
Yeah, that's a really important one too. I'm glad you brought up the rejection sensitivity and masking, because I was going to bring up burnout as a common phenomena that I see and I've experienced. And I think a lot of it is related to masking and trying to fit in with kind of social expectations, and it just being really difficult for people whose brains are just wired so differently. I mean, I could run around this room and it would feel totally normal to me, except for I'd make you all probably seasick trying to watch me. So I think that's a really good point. And that I bet almost all of us as kind of coaches and being in this space have had clients or heard burnout as being a very significant challenge for this community.
And this is the first time I've ever even heard the idea that the eating disorder I used to have in my 20s was somehow connected to me having ADHD my whole life. I've never heard that idea before. That's very healing. That's interesting. That's really interesting.
And I also just read that there's now studies that show that there's a strong correlation between early perimenopause for women with ADHD, that it can start as early as 36, which scared the crap out of me. So I read that article from start to finish immediately. So I think what we're saying is there is a lot of new information and a ton that we're going to discuss. So I won't let us get caught up in topic number 1. Let's move on, AJ. Is that okay, Emmanuel?
Okay, so now we're moving on to number 2. So it's assessing diagnosis and assessment.
Okay, and our speakers here are AJ, Kristen, and Catherine.
Okay,
I can go again first.
I'll go after you.
Roll. So yes, again, my angle is as a speech therapist and communication coach. So what I do is I treat diagnosable communication disorders if I'm doing speech therapy. So clinical treatment is working with these communication disorders that affect impact daily functioning significantly. So typical clients that I might work with are clients with autism or social communication disorders, or even acquired neurodiverse conditions such as aphasia after a stroke or traumatic brain injury. And targets for my speech therapy clinical treatment would be maybe working on pragmatics or social communication, even articulation and speech, and language disorders. They often co-occur with some of these, many of these conditions. And executive functioning strategies I might work on to support communication and help people become independent and improve their again, functional communication. If I'm doing communication coaching, it's more from a skill building enhancement angle. So I'm supporting people as a coach who don't necessarily have communication disorders, but they want to enhance that skill it could be for work, it could be for personal, specific personal growth, social growth. And my typical clients often are neurodiverse adults who feel maybe self-conscious, or want to present with more confidence at work, or with their partner who's neurotypical. So anyway, both are to optimize communication, but a little bit different. Yeah.
Very nice. I think it's, for me personally, what it comes down to is, because I'm neurodivergent myself, the way I frame this to my clients is that I am a neurodivergent career coach, right? So I am making sure they understand from the very beginning, it's not that I have a medical degree or that I have any business giving them an official diagnosis, which I would never attempt to do, but to help them better see it for themselves so that they can go to someone to get that diagnosis. That is part of the assessment process for us at Jess Dermo as well. But also I just think as moral, ethical, responsible adults, we want to make sure that we're never accidentally putting another human being down the wrong path, because we frankly do not know as much or as little. It's a Dunning-Kruger effect, right? We're trying to make sure that we're acutely aware that there are people in our field, like my dad's a physicist, right? So he knows a lot of what he does not know in his own field, and that's how he's able to assess, right? So that's part of it. What I spend a lot of time with my clients doing in the beginning, though, is stress testing the systems they do use. So I'm trying to get to a place in the beginning where I have permission from them to see what their executive function actually is, right? Walk me through the construction of the object and the mental mind mapping that you are. We're typically very high in our spatial reasoning skills. So that's why there's so many creatives that also happen to be neurodivergent. So I tend to lean very deeply into coming to the place of their imagination and having them walk me through what they're using. Think like the movie Brazil, Terry Gilliam, like where are they going inside? What are they naturally drawn to? And this gives me a lot of connective tissue with them. And again, it's also about how effective are those systems. So then we're teaching them the baseline. So again, it's things like back in the morning is I'm trying to see, what are you doing in order to start your day? What is your routine like? The lack thereof or the consistency of, because some of the people coming in have already finished college. Others have never held a job, right? So again, it is about helping them build a snapshot image, but with high contrast, the things they love, the things they hate, the things they don't mind doing, and then giving that to the other person without expectation for what you're going to get in return, so that they can now make a better judgment call for themselves, right? And if that's coaching with us, great. If that's, and I'm jumping the gun because this is actually going to be, I think, if was it questions 3, the next question, but it kind of bleeds a little, which is that therapy is meant for someone who has a personal, deep desire to heal something that requires someone who has a medical degree, who can walk through the fragility and potentially the medicating of someone. Whereas again, what we're doing in terms of diagnosis and assessment is figuring out, are we really what they need? Like I had a mother today who was basically grieving for her daughter, and her daughter needs someone in town in Massachusetts. So I'm going to build a list after this meeting for her tonight, because her daughter needs the accountability of showing up in person. Online, she'll be caught in the wind. It'll be used. We'll be taking $6,000 for no reason, right? So we're not going to do that, right? So again, that's my assessment of it. So, who was the third speaker for number 2?
That was me.
Oh, sorry, getting a diagnosis and picking a provider, right?
Well, assessing diagnosis and assessment. Is there a third
Yes.
speaker too? Yeah.
Yeah, in my work, I do refer out sometimes for diagnosis. I'm still learning what exactly ADHD looks like. I think the definition has changed since I studied the DSM 20 years ago, and the Diagnostic Statistical Manual, which we tend to use for diagnosis. But things are always changing, so sometimes I will send a client to get an official diagnosis with someone who this is all they do is diagnose autism, ADHD, neurodivergence. But if they come in with that diagnosis, and really for all of my clients, I love using somatic therapy. It really helps with, sensory grounding, self-stimulation, self-soothing, movement-based regulation, years of sensory overwhelm and masking do a number on the nervous system. I also do a little education around polyvagal theory, so kind of teaching them about shutdown, overwhelm, fawning, masking, how all of these nervous system patterns show up somatically, socially, emotionally. And then using acceptance and commitment therapy, really helping them with the identity work, the grief work about, what they feel life should be or what challenges they face, and helping them identify their values, where they can use boundaries. And then also with EMDR, which is eye movement desensitization and reprocessing. A lot of my neurodivergent clients come in with some traumatic experiences that created these core negative beliefs of there's something wrong with me, I don't belong, I'm not lovable. So using this process to help their brains and nervous systems reprocess traumatic experiences of being rejected, bullied, misunderstood. And that process also incorporates a lot of resourcing work. So kind of identifying strengths and resilience and what has worked for them. So that's kind of in a nutshell how I approach the work with this population.
Very nice. Very nice.
One thing, is that I know that we're sort of straddling two topics, and we'll probably shift into the other one. As far as, to me getting a diagnosis, and this is something, I've talked to some of the other people who are neurodivergent, is I've talked to some people where getting a diagnosis is really important because it feels validating. And for the validation, a lot of people don't feel like they need a formal diagnosis. In fact, I've been hearing a lot about some people from within the neurodivergent community who have been diagnosed, learning some of the assessments and then conducting them as a discovery process, and not trying to say it's a formal diagnosis, but more of a self-discovery. And so one of the panelists who wasn't able to join us tonight does ADHD assessments. Although she can't make an official diagnosis, she's still certified and trained. And so there's a varying spectrum of ways that you can get diagnosed. And it depends on what you want the diagnosis for. If you want more self-validation, you don't necessarily need to go through, the 3-day assessment. You can do discovery work, but for some people that's really important because they might want an IEP for a child or accommodations for themselves. And so because of this landscape where there are so many ways to learn, it's important to understand what you're trying to accomplish by getting the diagnosis. And I don't think anyone explained that to me, and I don't think I even knew that. And because it's so difficult now to get a diagnosis, I think it has kind of created more options for people to learn, because there are a lot of people who are in the dark about it and just want to understand. Manny, go ahead.
I just really appreciate a lot of the things that have been said so far in this conversation. And just to add a couple of plus ones to Emily, what you were just saying, diagnosis path isn't necessarily for everybody. One of the things that I think is really important about these conversations is that there's still so much education, right, that needs to be shared and communicated with those that are not as kind of up to speed on some of these details as the folks in this conversation. I really appreciate what Prescott had to share, that even at the PhD level, he's still learning, right? And there's still things that are coming out. I happen, just out of a place of interest, and also, Emily, to your point about self-discovery, found a book that was really, really eye-opening called Neurotribes by an author named Steve Silverman. And he goes through case studies from the origination of this research all the way up to about present time. And just, reading the case studies and how these things have affected different families was really eye-opening to me. And I think is just another point that these conversations are really valuable, because there's a lot of folks across the spectrum that will identify in different ways. And so us sharing our stories, us sharing our experiences, even without specific labels, can really be helpful to a lot of different folks. So I just want to thank everyone, but also encourage everyone to continue sharing your stories, to keep, sharing your experiences, because it is both therapeutic and also, I think, validating for a lot of folks out there.
Yeah. And then maybe we'll kind of work our way into the other topic that I know we're kind of naturally moving into. And maybe Marina can kind of help us transition from talking about, formal diagnoses to now other common treatments, as I know Marina has experience as both a clinical psychologist and as a coach. So maybe you can kind of share a little bit about your perspective on getting a diagnosis and picking a provider, and then transition us into continuing to build on other common treatments or services that you might share with the neurodivergent population.
Yeah, I mean, this alone is such a huge topic, and I might go down another rabbit hole if I may, because as we listening to the other panelists here and what was just said about the importance of educating the clients that we're working with, whether it's in a clinical setting, in a coaching setting, because for lack of a better way of saying it, it's still a hot mess, right? Because I find that there is, even as providers, we're still talking about, well, who does the initial assessment to begin with? So for example, you hear a lot that a primary care provider, that it is within their scope of practice to assess, diagnose, and treat. And then in other settings, it's no, this is a referral to psychiatry. Okay. And with psychiatry in general, there tends to be a much longer waiting list than primary care. So I do a lot of education, and it's great. And the client walks away, with information, and they feel empowered. But then in real life, there's still some confusion, right? Because they're given other information than what was discussed in our session, whether it's, therapy session or a coaching session. So I really wanted to start off there. So like I said, I was going to go down another rabbit hole. Great. Where do I need to go? Where do I need to return to?
Maybe you could just share a little bit about therapy and how you see that comparing to coaching for
Yeah, well,
especially for people who are neurodivergent.
yeah. Well, interestingly, burnout was mentioned earlier, and really the majority of my clinical caseload experiencing burnout, that because of the severity of burnout, they're now on medical leave, right? So they're out on a leave of absence. The majority of them also have a diagnosis of either ADHD or they're on the spectrum. And of course, that's not a coincidence. So yeah, in therapy, again, you're seeing a lot of depression, a lot of anxiety, co-occurring panic attacks as well. And that is the focus of treatment, regardless of what modality the clinician uses, whether it's cognitive behavioral therapy, and Kristen mentioned many other evidence-based treatments. Now, with coaching, I think the easiest way to look at it is that coaching is not treating anything. We're really looking at, how do you continue to grow, and what goals do you have, post therapy. Yeah, so they're not diagnosing or treating anything. It's really working with the client on what do you want to accomplish? What's getting in the way? What are the barriers? What needs to be addressed as far as like mindset and things like that.
Super helpful.
That was great. Yeah. And I was going to say, in my field, it's similar as well. Speech therapy requires a diagnosis, and coaching doesn't, and so that does guide the treatment in different ways. Yeah. And so for me, my speech language evaluations are based on what people are noticing they're having challenges with. It could be word finding difficulties. It could be I'm having trouble verbally organizing my thoughts or processing things auditorily, social skills, whatever it may be. And the big difference is like the accessibility in healthcare. We need the diagnosis if you want insurance to cover things. So yeah, I'm sorry. Were you done? Did you want to add anything, Myrna? Oh, okay, yeah. I was just gonna say, I'll continue with like how I would suggest finding a good provider, and I feel like this is not just for speech therapy. This is, but I'll tell you how you can find a good speech therapist or communication coach, and it's not a person who's trying to make you talk like everyone else. And instead, it's really, you're looking for somebody who's honoring your natural communication style. Whether you rely on literal language or if you're not comfortable with eye gaze, we're not telling you that you need to have eye contact, So yeah, I think it's important to look for somebody who's neurodiverse affirming, who's not pathologizing your differences, and yeah, who's supporting your authentic style of communication. Yeah. and offering these kinds of supports.
Yeah, it's very wise. I was going to say, just a reminder to everybody that we have 19 minutes left. So if we're going to have Q&A, we have 9 minutes to approach the other questions. So just reminding everybody. Emily, you're doing a good job moderating, actually. I realize this is a different beast than what I'm used to because we're all so quick-witted here. So you take your time with the list.
Better keep us moving, AJ. Topic 4.
Yes, correct. Topic 4, medication, management choices, and navigating options.
Okay, we've got Emmanuel, Prescott, and then Jasmine.
All right, I'll keep mine very short because I tend to be long-winded anyway. So AJ, thank you for the time check there. Basically, just what I wanted to share is just, I think, very related to some of the things that Kristen was saying earlier as far as learning the importance of being in tune with your body, and specifically how so many different things we experience in our environment have an effect on our nervous system. And for me, I discovered all of that through a major diet change about 8 years ago, actually showing my age a bit, about 10 years ago now that I'm counting correctly. But a lot of it just had to do with eating cleaner. And I realized that for me personally, I treat food as medicine in the sense that I've had to become very conscious of my intake and what that intake would do in terms of output, right? And so for me, and kind of learning through my own experience and being a very, very heavy journaler, even to the point of what did I eat today, and also how did my day go, and kind of tying those things together, and then looking back and kind of seeing the patterns and saying, well, these days I had really good days, and look at, you know, the kinds of things I was putting into my system versus the days that weren't so good. And that's been really helpful in the coaching aspect, especially because if we're working in a corporate environment, we don't always have control over, you know, what's for lunch or how many times am I making time for food. I, for myself, could just be heads down working and work right through lunch, right? And then not realize the negative impacts that has on me from a nervous system standpoint, from an executive function standpoint. So yeah, anyway, as I start to go on my long-winded tale, I'll pause myself there.
So I can go next. I was going to talk about medication, but I am, not a psychiatrist, so I'm not advocating for any kind of treatment for anyone. But what I've noticed in doing the research is that there's a whole range of neurodivergence, and some have some approved medications and some do not. I would say for autism spectrum, there are very few treatment options that are approved by regulators, and it's really in a very unique domain of irritability in ASD. Whereas for ADHD, there are both stimulant and non-stimulant medicines, so there's actually different flavors of treatments that are available. But even those some of them are new enough that they have been approved for younger individuals, like adolescents and children, but not even in adults. So I believe the stimulants are approved for any age, but the kind of newer, the guanfacine, the atomoxetine, are actually still restricted on their label to a younger population. And so that kind of leaves it to more off-label prescribing in order to treat some adults with anything other than a stimulant. So again, I'm not a provider myself, but that's just something to be aware of, that you have to speak to your provider about those different options and make sure they're right for you.
What if someone was looking for like natural alternatives? Is there anything that someone might want to discover or look for if they don't have like an official diagnosis, or if they just prefer something like alternative?
So I would say even that, if there are nutritional supplements that could be beneficial, you really want to talk to a dietitian or an expert in that, and maybe even get some blood work done and figure out where you might have deficiencies that you could try to supplement. And Emmanuel was talking about food. You could probably supplement a lot of those with eating good foods that are high in what you need, not necessarily taking something artificial into your system.
Yeah, and Jasmine, you offer something very different and have a great perspective on alternatives to medication. Can you share a little bit more about kind of what you know as maybe alternatives or additions to supplements to medication?
Yep. So from a recreational therapy standpoint, what we do is we provide leisure-based interventions that clients actually have motivation to be part of. And within that, we're actually, as therapists, we're strategizing how to help them achieve goals that translate into their daily life. So they can be self-advocating and their community is also well aware about them. So there's a safety standpoint for them. And then, of course, just in general, there's more and more research showing that different recreational activities such as journaling and meditation, they have been proven to be highly beneficial for mental health. And then it also translates into sleep patterns, memory, cognition, some of the things that, we tend to find more often in the autism category is, self-awareness and having a coping skill, a healthy coping skill when they are emotionally regulated. So I think one of the things that people don't realize is that being part of a healthy recreation activity while under the guise of recreational therapy, it also gives you a way to be part of the community and also be able to speak up for yourself and continue on without requiring a therapist to get you empowered and enabled within your own community. And that translates into every other health perspective too.
Thanks. So it sounds like there's a lot of range of options, and building on what you said, I was in conversation with a psychiatrist who said that there is some evidence-based research proving the relationship between yoga and being an alternative to a treatment-resistant depression treatment. So instead of like TMS, yoga was actually shown to be a really effective alternative. And now studies are showing something that a lot of people kind of intuitively know, which is that nature is really healing. It has now been shown to lower cortisol levels. And so things that we are instinctually drawn to that help regulate the nervous system or that just make you feel relaxed do have science and an evidence basis behind it. And so that's one thing when you are picking a service, it's important to understand and talk to clinicians. And it's also important, in my opinion, to follow and listen to your body. So I think Manny is the one who said that, and I'll echo that as well, because some of the research is behind, what most people kind of instinctually know, because it's science and we need to study and measure. And so just thinking about things is just because the medical and scientific community hasn't created the evidence basis for it does not mean that it doesn't work for you individually.
I can flourish something on that. Richard Feynman, who is a legendary physics professor, and he was Oppenheimer's right-hand man during the Manhattan Project, is famous for reminding all of us that science is the current best model. And 100 years ago, we thought that was the greatest model that we have, and now we think of it as antiquated. They will feel the same way about us in 100 years. So we always want to remember that that's the Socratic method at the core of the epistemology of science. It is a reminding an itch that man doesn't really arrive, that we seek. So now we just hit the 10-minute mark. Q&A. Oh, that's the other reminder. Okay, so Emily, I'm gonna give this to you. Do you want to start off some Q&A, start asking our wonderful audience if they have any questions for the panels?
Yeah. So we had a couple topics that we weren't able to hit on, but I think it would be great to take any questions that people have from the audience. And you can feel free to come off camera or type it in the chat. And if there aren't any, we can continue with the next two topics. But yeah, welcome to any questions. Okay, so we've got Marinette and Catherine talking on workplace strategies, daily living strategies, accommodations, leave of absences.
Yeah, I can say a little bit about both. To start off with leave of absence, obviously it's for individuals, whatever the condition is, that it is impacting, specific domains of functioning, occupational functioning, relationship functioning, and things like that. So we're really talking about when we are treating a clinical disorder. The challenge with leave of absences is that just to initiate it, it can be a very convoluted process. It also requires a lot of vulnerability on the individual's part to acknowledge that it has gotten to the point that I need extra help. I need to be away from this workplace environment so I can really dive into the treatment, right? To hopefully help me heal and recover from whatever symptoms are at hand. And so, however, again, just initiating the process can be very daunting. And I have found in my own clinical work that individuals have been thinking for a really long time to accept the assistance that they have a right to, right? Because just the process was just very scary. It was just too much. And in the meantime, they have been pushing through and then they're burning out further and further. So, it's really about educating not just the individual, but, educating workplaces. How do we make this a much kinder and more streamlined process? I mean, I'm sure there are many organizations that do this really, really well. But in my experiences, because I hear it directly from clients, some of these processes are quite abysmal. So who do you ask? Who do you trust in HR? What form specifically do you have to fill out? Is there a separate form because of the state that you happen to be in? Is the individual aware that there needs to be, progress reports sent to whoever is servicing the disability, on payment? So it can be a quite intrusive process, and a lot of people still don't have that awareness going into a medical leave. The next thing that I wanted to speak on is accommodations. A lot of people don't know what can I ask for? And so a really helpful resource that I just learned about several years ago, even though I've been assessing, ADHD for a really long time, is askjan.org. And so basically you go in, type in whatever diagnosis, and it gives a list of what are some of the recommendations, as far as accommodation. And in my work, whether, as a coach or even as a therapist, I really love to work with clients on developing like their own language so that they can self-advocate to ask, what do I really need in order to, really thrive in this workplace? Because if they're thriving, it's benefiting, right, the workplace. So as an example, because I think there's also a lot of bias with some of this terminology. Bias is still alive and well. When someone hears, oh, so and so is asking for an accommodation, right? And they have an automatic feeling. How does that feeling shift when they hear an employee say, hey, I've noticed that I am laser focused when I have my noise canceling headphones on? And would it be okay for me to continue? Right. And so at any rate, I could talk all day, all night about this topic. We need to do a workshop on this like soon. I have a lot to say.
I love that you mentioned askjan.org. And I also just wanted to mention Department of Rehabilitation. I have a physical disability, and they've been amazing. They helped me go back to school. Yeah, they've helped me in many ways. So that might be a good resource if you are looking for one. And yeah, I also work on self-advocacy, helping clients improve communication strategies. And so they might have challenges with executive functioning or communication itself. That makes it even harder to actually request these accommodations and explain why they need them, and set boundaries as well around their needs. So yeah, I think that's pretty much it. You did such a wonderful job, Myrna, explaining all of that. Yeah.
I know we're at time, so what I'm thinking, sorry, Manny, do you want to comment, and then I'll jump in again?
Thank you so much, Maria. Just really quick, just to kind of tie together a lot of the points that have been said, but also specifically in the workplace. Over the years, I've found myself doing a lot of work in diversity, equity, and inclusion. And unfortunately, these days, those terms aren't necessarily as applauded as they were about 10, maybe even 5 years ago. But I think the term that we really focus on now is belonging, right? And just the idea that even if you're not down the path of diagnosis, if you're in a hyper-competitive work environment, sometimes it just really doesn't feel like even an option you want to consider, right? Because of the human tendency for bias, right? But also the intersectionality community, right? So there are people that identify in a lot of different categories. And so if you're trying to bring your full self to work, you don't want to be looked at as less than, right? And so a lot of the things that I do in talent acquisition and people operations is how do we create those inclusive environments, both through systems and programs, but also through coaching. On an individual basis, it's helping people present as their authentic self without necessarily needing specific labels. And one of the tools that I found that's really useful, if anybody ever wants to learn more about it, is called a README. Which I borrowed just from the tech industry. Repositories have a README, which is essentially a cover page that lets folks know how to interact with this code. So helping individuals create a README for themselves, right? And being able to present that to a new manager or to somebody in HR, like, hey, this is my work style, this is my communication style. These are the things that I need in terms of work environment or downtime. And there's a lot of folks that really don't even know that that's exercises that you can do that just make your daily work life even better. I'm going down the long tail again, so I'll pause myself there. But thank you for giving me a second to share.
Yeah, and AJ, I'll turn it back to you. I'll just cross off my last topic. I could go on for probably an hour about navigating the complexity of insurance, and that doesn't sound like anyone's, fun Friday night.
Important.
So AJ, cut me off and please wrap us up and take us home.
Okay, so again, thank you everyone for joining us tonight. Again, this is an ongoing process. We need each and every one of us to be involved to help it evolve and become what it can be because of the sum of all of us working together in a mutual mission to help other people. Okay, we're seeking that help. Who maybe don't know yet that they need the help, and inviting them into Congress with us so that they can also heal and open doors for other people. Okay, so just again, thank you so much for all your time today, and just thanks for being also patient for us because we're also perpetual students too. We're always learning too. So I appreciate everybody.
Thank you, and have a great night, everyone. And thanks for joining, and thanks for speaking. This has been wonderful.
Thanks, everyone.
Bye. Good night.